points. I'm Dr. Caylor. I'm an interventional pain physician based out of Austin, Texas. And we're going to be going through and talking about sciatica today. What is it? Is it a notorious nerve or is it a rowdy nerve root? So thanks so much for joining me as usual. The goal of these sessions is one, education, trying to empower patients to advocate for themselves and their loved ones. And the other thing it's allowing us to do is really spend a little bit more time together as we dive into things that can be really, really challenging in pain medicine. So thanks again for joining me. As always, this is an interactive session. So whether you're watching live or whether you're even watching after the fact, post a comment and I'll try to get around to it this week and get your question answered. So today we're talking about sciatica. And the real question is, what is sciatica? What is the sciatic nerve? And so sciatica must be irritation to that sciatic nerve, correct? And we'll play into that a little bit more as we go along today. How do we treat sciatica? Is sciatica even the right name for this phenomenon we're experiencing? And today we're going to be doing a pain spotlight. Normally we do an anatomy spotlight, but today we're actually going to be looking at a specific pathology, and that pathology is lumbar spinal stenosis. And we're going to be talking about a procedure that we can do to treat that problem. So what is the sciatic nerve? When we talk about the sciatic nerve is really formed by the nerve roots of multiple levels. And we have to remember that in the spine, the spinal cord is in the middle, and it gives off these nerve roots that come out of the intervertebral foramen at each side. And those nerves come out and they form this spider web or meshwork of connections between them, and then they grow out into a nerve. And this one that we're talking about is a sciatic nerve. It's a combination of the lower lumbar as well as the upper sacral nerve roots that coalesce, and they form really two divisions. And you can actually see that here. It's the L4 through the S3 goes into this green aspect of the nerve, and there's two parts to it. The fibular portion, which is also called a peroneal, and the tibial portion. Now, the interesting thing about the sciatic nerve is really just two nerves in one. It's the largest nerve in the body, but it's two nerves in one, and it goes and it supplies the lower leg. And when you talk about sciatica, patients constantly come in and say, oh, I have sciatica. I feel it in my buttocks. And really, sciatica is a misnomer. Sciatica is really radiculopathy. It is some type of irritation that's going in a nerve distribution. So generally, as I said, the sciatic nerve supplies the entire leg. That is what we're trying to figure out. Peel away these layers of pain, figure out what's coming from the nerve root, what's coming from the nerve, and what's coming from all the muscles and other things that are kind of overcompensating in between. Like I said before, the nerve roots come together and they form two nerves wrapped in the sheath. That's the common peroneal and the tibial. And they supply all of the motor and sensory below the level of the knee, except for one patch, and that's the saphenous, which we're not talking about today. The sciatic nerve is a peripheral nerve, and it's not a nerve root. It is a peripheral nerve, and it is the largest nerve in your body. So what is sciatica? And sciatica is a form of referred pain that the patient feels in the leg, even though the irritation or damage is somewhere else. Now, sciatica can be entrapment of the sciatic nerve, or it can be nerve root irritation from a disc pushing on one of those nerve roots and pinching it. And when we think about that pathology, here you have actually a couple different pictures where you can have a pinched nerve, and depending on which nerve root is irritated, that will cause a different pain pattern into the leg. And that can allow us as pain physicians, as spine physicians, to identify where is that pain going, and as far as where the pain's going, what nerve root level is most likely at play here. So you can see the difference on the right here between a herniated disc, where you have actually the disc actually pushing out to that nerve, versus a normal disc that is actually doing what it's supposed to be doing, being that shock absorber of the spine. When we talk about referred pain patterns, we use dermatomes to figure out which nerve root might be irritated. And these are the classic ones, but it's important to remember, and I've been humbled by this myself. I mean, this is one of the most humbling things, where you is to have a patient come in and tell you, this is where I feel the pain. And I'm like, this must be an L4 nerve root distribution. And then you get an MRI and it's clearly not the L4 nerve root. I mean, but it might be the L5, it might be the L3. But these things are not exact science. These are guidelines to be able to help us figure out and generally locate where the pathology is. So we use dermatomes because in general, these are the cutaneous or skin manifestations of where you might feel something if something's pinched in your back. And so dermatomes of the skin are the skin sensation that's related to that nerve root. But it's also important, and one of the reasons pain is tricky, and I want to show you all these different levels. There's also something called myotomes, and that's the muscles that might be irritated, or where the muscle where you might feel the cramping that occurs when a nerve is pinched, or osteotomes, where if you feel bone pain from a nerve being pinched that is supplying that bone. So there's multiple layers here that make this really challenging for us to figure out. And it's why it's not so easy and there's no such thing as a painometer, because this takes a lot of work to be able to put all these pieces together to figure out where your pain is coming from. What's interesting is when you have myotome type pain or osteotome type pain, it might manifest as cramping or bone pain as opposed to that classic skin burning type pain or numbing tingling pain that we would feel. So sciatica or radiculopathy, pain shooting down the leg can be due to problems with the central nervous system, or it could be problems with the peripheral nervous system. This can be due to nerve or nerve root pinching, but it can also be due to trauma, inflammation, infection, tumor, or other insults. And so these are always things that we have to be thinking about. And how do we really know where it's coming from? And that's been the basis of this entire time, is talking about, I have to take the history, what you're telling me, and the imaging. That's what our studies and the MRI and everything that we know, the pictures of what the body is looking like, and that physical examination to be able to put the pieces of the puzzle together to really say, hey, this is where your pain is coming from. Our injections are extremely helpful. I know I've hammered this over and over again, they're not shots. When we do a targeted injection, like I said before, we have dermatomes, myotomes, osteotomes, these different referred pain patterns. You can have a nerve pinched at the spinal cord. You can have a nerve pinched in the sciatic as it goes down the leg. So figuring out what the pain pattern is, the injection can really be the tiebreaker when us as spine and pain physicians are a little bit kind of confused as to where this pain might be coming from. That injection can kind of help tip the tide towards one direction or another. It can be really, really helpful for us in getting the patient relief. And this is an example of what we would see on an MRI. So this is a T2 weighted MRI. You can see the spinal canal is in the middle, and then we also have the vertebral bodies in front, and we can see this disc herniation at the 4 or 5 level. And we can see, now this is right side, this is left side, we have this disc herniation that's coming out and contacting the L4 nerve root. This would give us a classic L4 nerve root sciatica, or lumbar radiculopathy is what we call it. And this is an example of that targeted injection. Now on this is the left and this is the right. This is an L4 transforaminal epidural outlining the nerve root. And this would be diagnostic if this patient came to me and said, I have complete relief of my pain after the local anesthetic was put on this nerve. That's diagnostic. We have all 3 pieces to be able to say, this is where your pain is coming from. And this patient would do really well with this therapy. So what do we do about it if we see we have sciatica and we've identified where the pain is coming from, or haven't? This is really where it takes a village. I mean, it's not just the patient, it's not just the pain physician, the primary care physician, it's everyone together trying to identify where the pain is coming from and utilize each of our specialties to get that patient better. And that team can include a lot of people: sports medicine, primary care, chiropractic medicine, physical therapy and kinesiology, spine surgery, right? Our orthopedic and neurosurgical colleagues that this is what they do day in and day out, is fix these type of disc bulges. Neurology, when we're trying to figure out, do we need an additional level of expertise here to be able to identify where something's coming out? Is there a concurrent pathology such as neuropathy that's going on that makes this case confusing? So it really does take a village to be able to know which way we should go with something. And so when we think about all of these different treatment options, we really want to think about this as a continuum. And we have things like observed physical therapy, which I think is absolutely critical for our patients. And it's not because I think going to physical therapy and doing the exercises is important, though it is. It's that you have an expert who's able in biomechanics able to sit there and actually watch the concurrent altered biomechanics that are going on to treat not only the primary pathology but also the secondary things that are going on as well. Chiropractic care, we have medications, we have interventions we do, such as injections and other procedures, and surgery is kind of always considered our final option. But it's important to know the evidence behind surgery, and we're going to do a talk about spine surgery down the road where we actually highlight the evidence for this. So this is really kind of getting to the basis of sciatica. Sciatica, in the most classic sense, is actually a radiculopathy or a nerve root disorder that causes referred pain down the legs, and we have a number of things that we can do for it, and we utilize the entire spectrum and scope of our practice to be able to treat that long term. So today we're going to be doing a pathology spotlight, and that pathology spotlight is on lumbar spinal stenosis. Now, earlier you saw an MRI that was a T2 weighted image, and you saw a disc bulge. Here we have another disc bulge, and it's at the 4 or 5 level where you have a posterior herniation of the disc. And as you can see, the spinal canal is quite pinched here. We have the spinous processes in back, the vertebral bodies in front, and we can see that this white stuff is the spinal fluid, and we have the nerve roots coming down in between. So the spinal cord terminates up here, nerve roots coming down, and we can see clearly there's not a lot of space. When the spinal canal becomes narrow, it obstructs the nerve signaling. And the reason that's important is the nerves have to be able to not just send their signals through there, but the nerves need blood supply. They need other things like nutrients themselves. So when that can't be replenished, that starts to cause other issues. And so you can see on the left side here, we have a healthy open spinal canal. And then with repeated disc herniations, you might get spinal canal stenosis. In addition to pain, numbness, and tingling, because that's what you think about with a pain physician, you also can have things like weakness, heaviness, and cramping. You might notice that your legs just don't have it. That oomph that they used to have is now gone. That's spinal stenosis. Spinal stenosis is this kind of constellation of symptoms. Where, yeah, you might have symptoms on both sides, but you get that cramping in the legs. Your legs not really having it like you used to. They're heavy. They feel weak. Classically, lumbar spinal stenosis will cause symptoms when you're walking or leaning back, but leaning forward and actually sitting down improve the pain and function. And so classically, we've called this the shopping cart sign. Basically, when you walk around without a shopping cart at the store, you can't do it. But when you walk around with a shopping cart and you're able to lean forward, you're able to actually open up that spinal canal, allow these nerves to actually do what they're supposed to do, and you're able to walk further. This is classic lumbar spinal stenosis. And this is an example of this right here. You can see clearly on that left picture, when you lean back, which occurs when you stand, when you walk around, when you do different activities, you're pinching that spinal cord. And that's a combination of degenerative disc disease, disc herniations, and arthritis in the spine. But when you lean forward, you tug everything open, and that allows the nerves to get all the signals they need to get down to the spinal cord, or down to the legs. So the procedure we're going to be talking about today is something called MILD, otherwise known as minimally invasive lumbar decompression. And it's an excellent procedure for patients that need a minimally invasive option with mild to moderate central canal stenosis, but in patients that have central canal disease. And in patients that have this, we can remove some of that obstruction using a special tool. You can see here on the right, you have this pinching of the spinal canal. And this green stuff is that extra material that can push in on the spinal cord. This is called ligamentum flavum. The spinal cord here, they chose this purple color, and obviously it's very narrow. Now, classically, these patients would also have some disc bulge, but this is just used to really isolate or to really demonstrate what we're talking about with the procedure. We can go in with a small tool and pick away at this and relieve that compression of the spinal canal, which will allow patients to have more room in the spinal canal. Does it fix the problem of degenerative disc disease and the degenerative cascade? No, but it does really relieve those symptoms. There are multiple randomized controlled clinical trials that have validated this technique for patients with this. And at 12 months after the procedure, patients had statistically significant improvement in pain, as well as a reduction in opioid requirement. At 5 years, 88% of patients that had this procedure were able to avoid surgical decompression completely. And that's a really wonderful statistic. And just like every therapy, just like surgery, just like injections, it's really important to find the right therapy for the right patient. And this is one that we're really excited about and able to provide for our patients. And I think the other thing about mild that's really, really interesting is looking at the percent improvement in walking distance. So how far can you walk without symptoms? How far can you walk without your legs not having it? How far can you walk before you just got to sit down because otherwise your legs are just done? And this is the really cool thing is when you look at just kind of your regular medical management, these patients were really not able to do much. But after mild, they were able to get extreme improvement with their ability to walk and before they got any symptoms. And that's a very, like I said before, this is a very simple procedure to go and pick this little bit of the ligamentum flavum out and reduce that spinal cord compression. So that wraps up our pain points for today. If there's any questions, I'll take them now. As always, go online, check us out, check out our other videos, and then join us every Thursday at 12:30. Leave a comment on our Facebook. Let us know what you want to talk about. Today, we talked about sciatica, which is a really challenging situation that many patients face, but we have a lot of options for. We talked about spinal stenosis and some therapies that we have for that. The important thing, as always, is taking the history, taking the physical examination, the studies we have, and trying to marry those together to figure out, one, where is the pain coming from, and use that information to predict which type of procedure or therapy the patient needs to best achieve long-term outcomes. Thank you guys so much for joining me. If there's any more questions, I'll take them now, but otherwise, I'll respond to you guys online, and I look forward to seeing you next week.